Uh, Feel free to use the chat box. We'll be coming to it at regular intervals. And also, we won't be taking questions in between so as the speaker's continuous flow of conversation doesn't interrupt. Okay, so let's begin today's session by introducing our eminent faculties. So we have two sessions. One is Introduction to Pediatric Palliative Care that will be taken by two of them. That is Dr. M.R. Rajagopal and Dr. Hariprasad sir. And the second session is briefly, we'll be talking about the activities which we follow in pediatric palliative care at our center in TIPS. Dr. Rajagopal sir, he's the chairman emeritus of Pallium India, and he's the director of TIPS. TIPS is a training and demonstration center for Pallium India, which is a WHO collaborating center for training and policy on access to pain relief. He plays a major role in various policy changes in the state across the country and is included, and he's including providing access to the, he improves in providing access to opioids. He has been awarded the Human Rights Watch Award in 2014, and in 2018, he was awarded the Padma Shri by the Republic of India. He has written a very interesting book, The Walk with the Weary, and I hope most of you might have read his book. It is mainly regarding his experiences with the patients and his professional journey. I welcome you, sir. Thank you so much for being part of this program and taking a session on pediatric palliative care. Next, we have Dr. Hariprasad, sir. He is a professor in pediatrics at Government Medical College, Ernakulam. He's in the field of pediatric palliative care for more than 15 years, and he has established a pediatric palliative care clinic in Government Medical College, Thiruvananthapuram, in association with Pallium India, which is a primarily center for children, mainly dealing with non-malignant condition. He was the person in bringing protocols for procedural pains in children, which is widely accepted across India. He is a founder member of the chapter of Pediatric Palliative Care in Indian Academy of Pediatrics, and he is also trainer of trainees in Pediatric Palliative Care, Indian Association of Pediatrics, and IAPC. I welcome you, sir, and over to you for the session. Thank you.
Okay, so thank you, Dr. Sangeeta, for that good words of appreciation. At the outset, hope I am audible, Sangeeta?
Yes, sir, you are.
Okay. So at the outset, I thank sincerely Rajagopal sir and the whole team of Pallium India for inviting me for this great session on pediatric palliative care. So I think so we'll go direct to the topic. So I shall share my slides. Is it visible? Is it clear?
Yes, sir. Screen share.
It's
yes,
okay
sir.
now?
Perfect.
Okay. So let us look at some clinical conditions. So I think this is a 12-year-old boy who got admitted in my ward about 3 months back. And look at the condition of the child. This is probably the most common condition needing pediatric palliative care in our setup in India, that is the cerebral palsy. And there are different types of cerebral palsy, and the most common is the quadriplegic, and they suffer from a lot of comorbidities. I think we'll come back to this child later when we discuss the symptoms. Look at this girl. It's a 13-year-old girl, again an adolescent, who had a complex heart disease in the newborn period, underwent a supportive surgery in the newborn period, but they didn't have money. So the follow-up was irregular. The corrective surgery was not done, and finally, child was practically in the home, breathless, even at rest, and the child could not go for the schooling also. This is another boy, an adolescent boy, whose diagnosis was a mucopolysaccharidosis. Again, it's a neurometabolic disorder having severe aggressive behavior and destructive attitude and temper tantrums, and extremely difficult for the mother or for all the family members to take care of him at the home. And he has got significant amount of intellectual disability. This is a 6-month-old baby. You can see the second of the twin having global development delay, having intractable seizures, and practically speaking, they were inside the hospital for nearly 6 months of life soon after birth. And in spite of all his problems, and the child was subjected for daily physiotherapy, and the treating doctor offered or told them that a new drug will come to the market very soon, and that will going to cure the child. And they were waiting for the arrival of this new drug. This is again a 4-month-old baby, again same condition, that is global development delay with intractable seizures. And this child was also practically in the hospital and with a hope of cure one day. This is an 8-year-old girl was diagnosed with acute lymphoid leukemia from AIMS Bhubaneswar. And they told them that the child had treatment for nearly 2.5 years. And after that, they told them that the child is not curable, so we can go for supportive therapy. But a lot of relatives of them are in Kerala, and they were told that if you come to Kerala, we can cure this child. We have a lot of coordinated therapy. So the next day, child landed in Kerala, and within a few weeks, child came to our casualty with a significant bleeds and intractable pain with a score of 10 out of 10. So what does all this indicate? So the burden of chronic disorders. So this is again taken from our own textbook, that is Nelson textbook of pediatrics, that shows that only about 6% of children needing palliative care are suffering from cancer. That means the remaining around 94 to 95% of children needing palliative care are suffering from non-malignant conditions. So what about the Indian scenario? The ICPs, that's International Children's Palliative Care Network, has estimated that about 6 million of children need palliative care in India. But I'm sure this is so much under scored, and the number of children needing palliative care significantly much more than this. However, we don't have a disease-specific registry, and just because of that, we don't know the true burden of the disease. So I just looked up the data in our own medical, that's the Trivandrum Medical College, which showed that about nearly 4.5 to 5% of children getting admitted in the ward need palliative care. And if you look at the ICU admissions, about 1/3 of the children getting admitted in ICU need palliative care. So I'm sure this will be the same scenario or the same statistics across India if we take the hospital statistics. So this takes us to the pertinent question of what is health. So we all know that World Health Organization has described health as a state of complete physical, mental, and social well-being. And recently they have added the spiritual component also. So it's a compound of physical, mental, social, and spiritual well-being. And it's not merely the absence of disease. So this takes us to the second question. So what is our responsibility in case of chronic illness? So will our responsibility end by just taking the decision whether to cure the child or not? So what is the solution for that? So I think we should, whenever we come across children with a chronic illness, we should always think in terms of care. And this is the like term, all of you know that cure sometimes, relief often, and comfort often. So whenever we deal with the chronic illness, we always focus on relief of symptoms and comfort of the child and the whole family members, and that is palliative care. So what is the definition of palliative care? Yes, this is the definition of palliative care. Pediatric palliative care described by WHO. It is active total care, not only of the child, but involving the whole family. We always focus on prevention and relief of suffering. You focus on the physical, the psychological, emotional, social, as well as the spiritual aspects. So disease is not the criterion. So whenever we come across any severe health-related suffering, we should offer palliative care for these children. So the next question, that is, when should we start palliative care? Again, the World Health Organization has come out with the clear guidelines, and they have said that the care should begin when the illness is diagnosed. So as soon as the child with a chronic illness is diagnosed, we should start palliative care for the child and the family. So again, probably the pediatricians are very fond of looking at American Academy of Pediatrics. So what do they say? So they also say the same thing. So American Academy of Pediatrics also say the same factor, that is the palliative care should be offered at diagnosis and it should be continued throughout the course of illness. So there is no doubt, whenever a child is diagnosed with a chronic illness, we should start the concept of palliative care for the child and the family. So this is a new model. As soon as the diagnosis is made, we think or we take a decision whether cure is not possible. If cure is not possible, then we will try to control the symptoms. So we start the disease modifying treatment and we start palliative care along with that. And as time goes on, the palliative care aspect slowly takes over completely. And finally, the child will land into the terminal phase where we go for end of life care, and we will never abandon the child or the family. After that, we'll continue to support the family through bereavement program. So this is a new model of palliative care. So what is the difference between conventional treatment and palliative care? So palliative care is always patient-oriented. You always focus on the healing. Our goal is quality of life, and we always accept death as a reality. And this is very important. We will never postpone death of the child, compromising the quality of life. So we always accept death of children, and we always focus on the quality of life for the child and the family. And it is very, very valuable in chronic progressive illness. So this is the total framework, that is we focus on the physical, social, emotional, and spiritual aspects of it. So having discussed the definition and when to start, now let us look at the various categories of children needing palliative care. So this is again taken from our own Bible, that is Nelson Textbook of Pediatrics. So this is the category 1, that is the disease is life-threatening, curative treatment is available, but they may fail. And this is the classical heart disease condition I told you comes under this. Is the complex and congenital heart disease comes under this group. And this is the trajectory. We make a diagnosis, there is treatment, there is remission, but so there's the treatment and remission relapses continues, and finally death occurs. Probably it may take many years. Category 2, here there is long period of treatment is available. It will definitely prolong the life, but again, premature death is always anticipated, and most likely that will happen also. Various conditions like the muscular dystrophy, that's the Duchenne muscular dystrophy, the various congenital myopathies, all cause of chronic respiratory disease and various immune deficiencies comes under this group. So here they will have an adequate period of stability, but after that they start developing complications, and again there will be a lot of remission relapses, and finally death occurs. The third condition is we cannot cure these conditions, and that means the disease is progressing as soon as the diagnosis is made, and the treatment is palliative starting from diagnosis. So various inborn of metabolism, the neurodegenerative disorders, the child with the mucopolysaccharidosis I showed you, the various syndromes, as well as certain cancers where no curative treatment is available comes under this category. And this is the illness trajectory. Here the diagnosis is made, and death occurs sometimes months later, but sometimes years later. Definitely the treatment is always supported. This is the last category, that's a category 4. Here there is severe disability that leads to extreme vulnerability to complications, and again premature death occurs. Probably the most important almost all causes of in children non-malnutrition conditions comes under this group, and that is all types of cerebral palsies, the post-encephalitis sequelae, brain malformations, as well as or the on top cause of brain injury secondary to hypoxia and trauma comes under this category 4. So here also we make a diagnosis. They'll have remitting and relapses courses, and finally death occurs, but that will take years. They may go up to 20 or 30 years or even beyond that. So having discussed the various facts, what are the facilities? So I think as far as pediatric palliative care is concerned, there's a huge gap between the reality and the facilities. We know that India is the most populous country with more than 140 crores of population, and we must be proud that, and our children population comes to more than 50 crores, that is nearly 1/3. But if you extrapolate the data from United States, it shows that will show that around 6 crores of children among the 60 crores are suffering from chronic illness, and definitely they need palliative care. And we know that India is a huge country, a vast country with more than 2,000 ethnic groups, 29 accepted languages, and a wide variation in all the aspects, whether it's a social, financial, cultural, educational aspects across India, from north to south or east to west. And this is on the left side, we can see the reality. We got only very few centers across India, and almost all of them are situated in major cities like Bombay, Delhi, Pune, Hyderabad, and Kerala. And I'm very happy to say that our center, that is TIPS, Trivandrum Institute of Palliative Science, is one of the major centers offering pediatric palliative care to the needed children. So whenever we offer palliative care support in children, and we should keep these four aspects in our mind, because all these aspects are exclusive of pediatrics. That is the growth, development. We should focus on the speech and language, motor, cognition, active daily living. Always look at the macro and macronutrients, because we should ensure at least 100 calories per kg per day and a protein intake of 2 grams per kg per day, and always focus on the immunization also. So whenever we deal with children with cerebral palsy, just one or other conditions, we just one caution, because if we see children having clustering of cerebral palsy children in the family, or there's a history of consanguinity, or if there are two or more persons in the same family having similar symptoms of cerebral palsy, this could be a cerebral palsy, may be a metabolic disorder. Again, similarly, syndromes can recur in family, and behavioral disorders. Many children are diagnosed with a psychiatric illness, but they may come under a neurometabolic disorder. So why this is important? Because if we diagnose early, they can screen the mother in the antenatal period, and antenatal diagnosis is possible, and we can help them to have a normal sibling in the next pregnancy. So this is very, very important. Suspecting cerebral palsy mimics, suspecting syndromes, and suspecting neurometabolic disorder. Okay, so this already discussed. So what are the various symptoms? So now we'll be focusing on the main symptoms of children with pediatric palliative care. If we take the neurological conditions, they have seizures, hypertonia, spasticity, and contractures, and varying amount of intellectual disability. A lot of causes for respiratory issues, prone to have aspirations. They may become oxygen dependent. They can have cardiac lesion leading on to dyspnea, exertion, fatigue. Almost invariably, all of them may have bowel and bladder involvement, a lot of feeding difficulty due to multiple reasons. So practically speaking, almost all the systems are affected. They're physically dependent, and the quality of life is significantly compromised, not only for the child, but for the whole family as well. So whenever there is a chronic illness in the child, there is significant disability. They've got multiple comorbid factors. Their lifespan is limited, but go for years, and they're completely dependent. We have a lot of, and it is not time-bound when we compare with cancer. And we must always focus on the functionality and rehabilitation. And when such a child is taken to a local hospital, or we have got a lot of Wi-Fi hospitals across India, but all of them give disease-oriented treatment. There is significant patient overload. We spend the same amount of time for a child with an upper respiratory infection as well as for a child with cerebral palsy. They got all different modalities, but all of them work at different sites. We have got cardiology OP today, neurology OP tomorrow, nephrology OP day after tomorrow, etc., etc. And one fine morning, we just discharge the child and we fail completely to continue the treatment at home. And we got miserably failed in providing psychological, social, spiritual, and financial support. So what do they need? Yes, we had to focus, we had to improve their quality of life. Symptom management is very important, and we had to support the whole family. So what is our role as a palliative care pediatrician? So we need to act as a clinician who provide the complex needs. We should focus on high quality primary care. Preventive care, especially covering the dental cases, is very, very important. Always go for immunization, and we should help them to have a continuity of care, and always help them to have an access to urgent care. And as soon as the child is about 12 years in government hospital or 18 years in private hospital, we ask them to review in a physician. So the transition to adult care is also very, very important. And we should help them to have a shared decision. And so I think we already discussed. So nutrition support is very important. Always respect the cultural and spiritual aspects, and we should be able to provide them, the child, a good death and continue support with bereavement program. So these are the 4 cardinal principles: patient autonomy, beneficence, non-malfeasance, and justice. And we go by these headings: correctly correctable, non-pharmacological measures, and pharmacological measures. And again, symptom management, the MI is a short form, or the mnemonic: evaluate, explain, manage, monitor, and attention to detail. So this, I think we already discussed: reduce hospitalization, advanced care planning, and resuscitation directly, and plan for the unexpected. So we should help them in their needs and through symptom management, through proper communication, meaningful hopes, and shared decision. So what are the symptoms? We know pain is probably one of the important symptoms, and we know the concept of total pain, that is the physical, social, psychological, and the spiritual components. And when we discuss about physical pain, all of you know the WHO analgesic data, the step 1 and step 2, along with that adjuncts. The spasticity and contractures. Yes, the spasticity is very, very important because almost all of them have or some amount of spasticity. And whenever we deal with a chronic illness, we always focus on functional level of rehabilitation, because our focus is on functional and comfortable postures and not complete reduction of spasticity. So this is very, very important. So whenever we deal with children, focus for ambulation, sitting, on sleeping. So decide on individual basis and focus on the level of spasticity needed and plan the treatment. And again, it is a non-pharmacological, pharmacological, and supportive. So the non-pharmacological measures, that is the physiotherapy, exercise, massage. The common drugs we use is the diazepam, baclofen, and tizanidine. And if the child has got local spasticity, we can go for botulinum toxin. And beware that uncontrolled spasticity can lead on to hip dislocation, scoliosis, which can lead on to severe pain as a respiratory compromise. And in selected cases, we go for surgical corrections. So this is the treatment for spasticity and contractions. Seizures, we had to modify the drugs of the anti-epileptic drugs based on the weight per kg. So because you know that in pediatrics, all doses are decided on based on milligram per kg. So titrate the dose of anti-epileptic drug drugs at least once in a year, if possible by within 6 months. And if we know that the fever can precipitate a seizure, and also this age below for febrile seizure. So you give clobazam along with the paracetamol at the onset of fever, and always stock paracetamol and diazepam rectal suppositories at home, and teach the mother to use midazolam nasal spray also. Dystonia, please remember that some drugs can cause dystonia, so be aware of that. And pain and fever can aggravate dystonia, so control pain and fever. And the drugs used are levodopa, trihexyphenidyl, and tetrabenazine. For a child with a cerebral palsy, I think we already discussed seizures, spasms, and contractions. And agitation, neuroirritability is another important symptom, that is they go for uncontrollable incest and crying. And the approach is correctly correctable, that is correct all the measures that is possible. Rocking and positioning is important. And we can go for massage or vibration. And the drugs used for neurointibility are gabapentin and amitriptyline. For kyphoscoliosis, restricted lung disease, we can go for bracing, chest physiotherapy, postal drainage, oropharyngeal suctions, and home oxygen. And for micro and macronutrients, always go for the nutrition rehab day I have already mentioned. Children with intellectual disability. So as far as possible, classify the intellectual disability, and if possible, grade them, and always focus on the activities of daily living. And many a time we can go for occupational therapy also based on the level of intellectual disability. And for destructive and aggressive behavior, these are the two drugs commonly used: methylphenidate, that is 1 milligram per kg per day, and risperidone. So please be aware of or take these two drugs into conference, and any MBBS doctor can prescribe this drugs, methylphenidate and risperidone. If the child has sleep disturbances, we can go for trichlorphorose or melatonin. Breathlessness is another very important area. So they may present as cough or respiratory distress, sometimes disturbed sleep or headache, or sometimes polycythemia may be the only presence of or evidence of symptom in breathlessness. So how to manage? Correct the correctable, that is the child has got pneumonia, correct that. Asthma, correct that. Aspiration is there, treat that. Non-pharmacological measures and pharmacological measures. What are the non-pharmacological measures? We can go for normal oxygenation ventilation. Home oxygen can be provided through oxygen concentrator. Airway clearance is very, very important. For that, we can go for postal drainage, manual vibration, abdominal binders, or oropharyngeal suction can be done. If there is increased secretion, we can go for glycopyrrolate. To thin out secretion, we can nebulize with 3% saline and N-acetylcysteine. Again, physical therapy, especially over the abdominal and trunk muscles, and postal drainage is also very important. And please give all the vaccines of UIP and also yearly influenza vaccine, because the commonest cause of respiratory distress in a child is a common respiratory infection getting from the school-going child or the sibling. And always go for the pneumococcal vaccine also. And as we discussed earlier, chronic respiratory distress can lead on to chronic respiratory disease, can lead on to pulmonary hypertension. So if possible, results are available, please go for echocardiogram, because pulmonary hypertension can lead on to malignant arrhythmias and the child can have a sudden. So please keep this point in your mind. So we know that morphine is a drug of choice for children with a breathlessness in palliative care setting, and this is the dose. And any handwriting morphine should prescribe antiemetic for first few days and stimulant laxity. How does it act? Yes, it acts on the carbon dioxide sensitive mineral respiratory center, makes it less sensitive to carbon dioxide accumulation. It slows down the respiration, reduces the inappropriate excessive respiratory drive, and there is a relief of comfort for the child. So always you start morphine also when in all these children with the breathlessness. You can add benzodiazepines if the child has significant anxiety or there are panic attacks, and the common drugs used are the lorazepam and the midazolam. And lorazepam can be given 8-hourly, and midazolam is available in the various doses. It is available as oral, infusion, as well as nasal spray, and generally we can go for oral midazolam. GERD is another very important situation, lead on to aspiration. So these are the measures: keep the child in upright posture, thicken the feet, avoid acidic foods. Please keep the head and elevated, and do not use pillows. So please avoid pillows for managing GERD. Elevate the head end of the bed, and always you go for PPA, proton pump inhibitor, and domperidone. That will bring down the level of GERD. If the child has got spasticity, please give baclofen, because of spasticity aggravates GERD. Other measures, I think we already discussed, that is focusing on nutrition, nutrients, as well as immunization. And the commonest source of infection for the children is dental caries. Almost all of, I must say, more than nearly 100% of children suffer from dental caries. So annual checkup of the dentition is very, very important. and always correct the vision and hearing if possible, because correction of vision and hearing significantly improves the quality of life of the child. So feeding problem, we already discussed, that is spasticity, treat it. Pseudobulbar palsy, to counter, we can go for Riles tube feeding, and probably if they can afford, we can go for pediatric induced gastrostomy. That is, if possible, it's a simple measures, but it's a costly affair in as far as in India is concerned. But if possible, we can go for that. GERD, we already discussed, and aspiration can be prevented by managing spasticity, proper position to prevent GERD, managing pseudobulbar palsy, as well as thickening feeds and upright posture. Excess secretions, I think already discussed. And another important point is constipation. So please include fiber in the diet, and give stool softeners as well as laxatives. That is, so that will relieve the constipation. And almost all these children will have some type of bladder symptoms. There are different types of bladder, and so try to find out the type of bladder, and the commonest cause is uninhibited bladder. And based on that, we can design the drug to be used, and clean intermittent catheterization will solve some issues. And so I think the discussion is not complete unless we cover the psychological, social, financial, spiritual aspect. And Rajagopal sir will be covering that in detail. So this is our aim. That is, we start from goal of cure. We'll go on to goal to prolong a life of good quality, and finally we optimize comfort at the end of life, with always going hope, and that is meaningful. So to conclude, I think what is palliative care? So pediatric palliative care is nothing but clinical medicine with empathy. Always consider the possibility of total pain. Let us own morphine rather than fearing it. Symptom management is very, very important. Complete diagnosis using, including genetic confirmation, very important whenever they deal with a chronic illness. Active listening and art of communication is very, very important. We must be true to our children and their families. We must provide them meaningful hopes. We should help them to take shared decision, and we should always shoulder the responsibility. We should always respect the patients and their caregivers. And our focus is always quality of life, and we always focus on adding life to their lives. So palliative care is a need of the hour, and everyone, all health workers in palliative care should have an exposure to the principles of pediatric palliative care. All major hospitals should have a palliative clinic, and we must be able to provide palliative care wherever we are, whether in the hospital, clinics, community. So we know that India is a huge country, a large country with a lot of difference in all the aspects, from north to south and west to east. And let us join hands together to provide palliative care to all the children we come across. So I thank you. Quoting this great Swami Vivekananda, Usishtada, Jagrada, Prapya, Vadani Bodhana, meaning arise, awake, and let us not stop until the goal is reached. So thank you all for the patient hearing. And the clinical scenarios I mentioned in the earlier phase can be discussed if time permits in the discussion. So thank you all for the patient hearing. And thank you, Rajagopal sir, and thank you, Team Palliative India, for giving me this wonderful opportunity. Thank you.
Thank you so much, sir, for taking us through the concepts of the most important aspects of pediatric palliative care. Definitely, this was very interesting and an eye-opener for many of us. So without any delay, we will move on to Dr. Rajagopal sir's presentation. Over to you, sir.
Hello, everybody. Good evening. Many familiar faces, but more unfamiliar faces. Good to meet you all. Sangeeta, thank you very much. Raju, thank you. Hariprasad, thank you for laying the ground. You have covered a lot, and maybe I can chip in with a little more. Raju, will you give me about when my time is up, will you give me a 5-minute signal?
Yes, sir. I will do it.
Thank you, thank you. So friends, we all love children, don't we? Children are very dear to us. Think of your own family. And I think at least in a few of the audience, there must be a child cuddling under the chair, holding on to a mother's or dad's leg. We love children, but we generally don't understand them. Generally, we do not consider them human beings. Oh, they are our pets. We forget that they have emotions. We forget that their emotions are important. If you are in pain, you will have the pain treated. But if a child is in pain, often you will tend to ignore, oh, I don't want to put him in any danger. I don't want her to suffer from any side effects. And then we'll say meaningless things like, my child is a fighter, he will fight. So first message is consider your children and your patient children as human beings with a personality. Everyone has a personality. They have their emotions. And we have to understand the human being in the child. And as Hariprasad so succinctly put, access to palliative care is very limited in children. We can't easily measure that, but if you look up palliative care, only pain relief in the whole country, less than 4% of the population has access to it. And if you consider children needing palliative care, less than 1% has palliative care, has access to palliative care. Even palliative care doctors treating adults sometimes say, no, I don't have training in pediatric palliative care. I cannot see the child. And in our country, very often, in most places, there is no one to send the patient to. That means you are condemning the child to a life of agony. So you all have such an important role to play in this country for the future. We are still taking baby steps. And here I am glad we have this group who will together take it forward. I'll start by sharing the screen. I just noticed that John Marston, hey, hi. Glad to see that you are here. I haven't seen you in about a century and a half. Good to have you with us. So John, just raise your hand electronically and chip in whenever you can. You have about 153 times more of experience in children's palliative care than I. Do please help. So let me share my screen. Kerala has at least 16 times more palliative care than the national average. Yet this happened in our state. This happened many years after Kerala had a palliative care policy. After there was a palliative care professional installed in every primary health center. Still, read this sad story. The parents hung themselves after strangling the child. This was not a child with cancer. It was a child living with a non-cancer pain, neurological problem. and severe spasm of muscles, which can be absolutely cruel. So friends, together, this is the kind of thing that we have to avoid. The suffering of the children and the suffering of parents. And this is from Hyderabad, from the Regional Cancer Center. Dr. Sudha Sinha, a pediatric oncologist, published this study. I've given the reference in the bottom. Do please take a look at it. They found that 75% of the children had received chemotherapy. Children with cancer had received chemotherapy in the last 30 days. And 50% of children who died with cancer had received chemotherapy within the last week. Sometimes unexpected things can happen. In a Euro-American country, comparable figures would be 20% in the last month and 10% in the last week, even which is questionable. Why does that happen? That happens because people are afraid. Fear binds our arms. Because of fear of telling the truth, because we have not learned how to tell the truth. We avoid saying that and say things like, let us wait for the pain to subside, then we'll continue chemotherapy. And the child and the parents will go from doctor to doctor, doctor shopping, seeking treatments. So children already do not get palliative care and have additional suffering inflicted on them. Now, I will not talk about this aspect later, but friends, do please give attention to this. The pain inflicted by procedures in our country is atrocious. A child is snatched away from the mother by the heftiest attendants and practically bent out of shape for someone to do a forcible lumbar puncture. And bone marrow puncture, we all know that periosteum is one of the most sensitive parts of the human body. And we do it with absolutely no attempt at relieving the pain. And people with burns, oh my God, I think we must worship the people working with children with burns in our country, because children are not given pain relief. And children with chronic pain. These are some of the gaps which I hope we'll be able to correct. And Hariprasad mentioned this, the intensive care cruelty in our country. This is another area where we find it very hard, because we need expertise both in palliative care and a little understanding of respiratory support to be able to help them. But sorry, that came out of order. My apologies. I mentioned procedure-related pain. This medicine has been available in India for more than 22 years. It is called eutectic mixture of local anesthetics. Friends, at least remember this for your own child's sake. When they need a venipuncture or a intravenous puncture, even blood drawing, it would be an amazing difference to apply this cream. Cover it with a piece of plaster. Take out the plaster in 45 minutes and the skin would be insensitive. Oh, it won't be available in every medical shop. But wherever you're practicing, you ask the medical stores to procure it. They can. It's available. And I will not go to the rest of possibilities of procedure-related pain. And Dr. Hariprasad actually talked about him. And I do not have the time today to go into the details. Then why am I saying it? I'm just to highlight the point that these are things that you have to learn yourself. most procedure-related pain can be significantly alleviated. Now, with the limited time I have, I want to talk to you about, I've made the screen blank for a minute. I'll come back to it because I want you to understand this. If you are not aware of this already, this is not only about your child patients. This is about your own children. They need to understand them. And depending on the age, their understanding and their reactions change. Up to an age of 2 years, the predominant need is for physical comfort, and you know how the child cuddles up to you. Of course, symptom control is vitally important, and avoiding procedure-related pain is important. But even at that tiny age, if you cause parental separation, the consequences are going to be horrendous. Lasting emotional damage can be done. Insecurity. Don't think that post-traumatic stress disorder is only some problem of grown children or adults. There we'll be able to see it more. Here we will not even be able to understand. So Dr. Hariprasad, I am waiting for the day when you become the head of the department in one of the medical colleges, which should be happening any year now. And I hope you will establish the first intensive care unit in the country where you actively encourage presence of a parent with the child, and encourage the other parent to visit.
Okay, thank you, sir.
How much longer, Hari? Are you almost there? He's too modest to say. Okay, let us hope it happens soon. And remember that isolation in hospital is as bad as imprisonment. But ICU experience is worse than putting the child into a prison, because we are inflicting physical suffering in addition to separating the parent. And the ICU experience, this is known. There are data to show that an ICU experience may cause as much post-traumatic stress disorder as in victims of torture. The percentages are very similar. Now, when we go to children who are a bit older, I'm sure many of the participants will be thinking of your own child who is at that age gap, 2 to 6 years. Children till the age of 5 or 6 cannot grasp the point that death is final. If somebody says, sorry, your father is dead, the child will say, so when will he come back? If I am a good boy, will he come back? If I am a good girl, will she come back? These questions will be asked. And that's very difficult for the child. And if they say, no, your father has gone to heaven, the child might start thinking, okay, I did not obey my mom the other day, and that's why she got angry and left me. These are things to be compensated by affection and physical comfort, and the remaining parent's action that I am here for you. I am going to look after you. They need explanations. I'm not saying that they do not give them explanations. They need explanations and reassurance, not only by words, by action. So we talked about children up to the age of 2 years, up to and now 2 to 6 years, but let us understand that at this age also, parental separation can be very harmful and has to be remembered as an important point in the management, ensuring parental presence. When children get a bit older, they tend to fear abandonment. If you have taken the child away from the parent, even if for 1 hour, to do a bone marrow puncture, if the parent can take it, I'm only saying things that I actually did. As an anesthetist, I have often had to do these procedures. And okay, sometimes things do go wrong. Sometimes a parent faints. Okay, look after them. But that doesn't mean that we will not allow any single parent in, because they are allies. We need them. When my own son needed a minor surgery, he was, I think, 8 at that time, and the only condition he said that you should stay with me till I am unconscious. So during the venipuncture, until the anesthetic went in, I stayed with him and held his hand. I'm saying that these things can be done if you are not in authority now, if not today, tomorrow. And remember, these children have short attention spans, as all teachers know in schools. You give them a lecture, you would have lost them after the first minute. Explanations to small kids have to be short and succinct. And these children have to be given some participation in decision making. You want to start chemotherapy, you tell them. They will say no, 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 no. But you persist and say you have to have it. Yes, but please tell me what I can do to help you reduce the suffering. I'll hold your hand. I'll be here for you.
So just to interview, you have another 5 minutes to do, sir.
I think that voice broke. Who spoke?
This is Rajagopal, sir. You have
Yeah.
another 5 minutes to.
Okay. Thank you, Raju. When children are even grown up, there are more problems above the age of 12. When we have to tell them about death, can you? It's not easy. It's not difficult either. If you decide to do it and start learning to do it, we have to be honest with them. We have to be slow, give it piece by piece. And remember, even a doctor sometimes cannot take what you can do for an adult. And if your eyes become moist, it's okay. It's more important to be honest. And even children discuss funerals, etc. And I wish I had the time to tell you some stories from Elizabeth Kubler-Ross and her experience. Her book about death and dying is something that I'll recommend all of you to read. And even when you have given very bad news, like death, you will have to keep hope alive. But so long as you are here with us, we will be here for you. When you have problems, ask to see me. We are going to make you as comfortable as possible all through. You are loved. These are messages that are important. And please remember, children's faith is not usually like ours. Most of us are cowards and do not say whatever we feel, and inside somewhere, is there really a God? We question that. They don't. And very often, if they have the faith, it's a great way to give them relief, to pray with them. But this is not the time to squeeze God down their throats. They are not believers already. And they live with us. They may have guilt. It all happened because I was a bad boy. I did not pray hard enough. Will God punish me? These are fears that they'll be able to ask you. And these are things that can really help to improve the child's quality of life. And those of you who have teenagers know how difficult that time can be. They are human beings struggling to be independent, at the same time wanting a cuddle, and they struggle with that. And that's when they fight. When they're already busy with being a teenager, a disease coming in. And when they felt they were on top of the world, their very existence being challenged can be very tough. They need understanding. They need your patience and non-judgmental approach. And if parents cannot do it, we will have to step in. I think everyone has to prepare yourselves for this by reading up more and trying to empower yourself. Before I stop, let us remember the unseen patients, siblings. There are two extremes that can happen. The whole concentration of the family is on the child who is ill, and the sibling grows up feeling nobody loves me. Everybody is angry with me. I might as well die. And sometimes siblings wish they had the siblings' illness so that they also could get a cuddle. On the other extreme, like this child whom Hariprasad, I don't know if you were there at the first palliative care clinic that we did in SAT hospital. This child was there as the total caregiver for that baby.
Yes, sir.
The child was 10. And we force impossible burdens on them. And finally, parents. You all have learned about the Kubler-Ross 5 stages of grief: denial, anger, bargaining, depression, and finally, hopefully, acceptance. Harder in the case of parents. And in the case of parents, particularly guilt needs to be mentioned. I wish I had taken the child earlier. He had fever thrice and I did not take it seriously enough. They blame themselves. They blame their spouse. You did not do this. I told you to do this. You did not. And they fight. At a time when they should have been together, giving comfort to each other, they are angry and they fight very commonly. They need your understanding. Help to get back together. Initially, it may be good to listen to them individually and then to get them together, to talk it over. Express anger sometimes, but also to cry together. And if a child eventually dies, as Hariprasad said, these children or parents of children need more support during the bereavement phase than people who have lost a loved adult. And let us remember that in the definition, I'm not going through the definition, but support to the family is an important part, very important part. So thank you, friends. The family, the child with the illness, the sibling, the mother, the father, the other child, all being together and given care is the essence of palliative care for children. Thank you very much.
Thank you, sir, for making us understand the importance and showing light on the importance of focusing on child's pain and the ignorance we have in this aspect. The presence of parents and the communication part is also as important. Thank you for taking us through. Next, we have the second session. So it will be taken by Dr. Sunilkumar, who is going to take are going to show us the activities of pediatric palliative care in our center. And he'll be sharing his experiences in this field. He's the additional director of TIPS, which is a WHO collaborating center. He has over 20 years of experience in palliative care, and he is the honorary tutor at the School of Medicine, Cardiff University, and also a national faculty in palliative medicine. He is the ex-Central Committee member of Indian Association of Palliative Care, and he is a mentor for quality improvement projects under EQUIP India. He's been awarded with various recognitions and over these years, and he has written many chapters in various palliative care textbooks. Thank you, sir, for taking the session for us, and over to you.
Thank you, Sangeeta, and good evening, everybody. So I will be sharing my presentation, and I'm not only concentrating on pediatric palliative care, but the activities done by the Palliative. Am I audible, Sangeeta?
Yes, sir, you are.
So Palliative India is a national registered charitable organization formed in 2003 with the aim of relieving serious health-related suffering in India. And we know that there are many people, there are maybe 5 to 7 million people who actually need palliative care in India, and we are only able to provide palliative care up to 4%, maybe 3 to 4% of patients. But we want to improve the palliative care status in India. We alone would not be able to reach all these patients, but we are sure that all of you will be able to take this to many patients so that we can achieve that goal. And the Palliative India works by this model by demonstrating what we do at Palliative Care Center, and by educating the professionals and public, and by facilitating the formation of palliative care centers across India. So we provide palliative care in 4 models through inpatient care, outpatient care, home-based care, and telehealth care. So in our inpatient units, we have about 14 beds, and we admit any patients with serious health-related suffering and whose suffering cannot be relieved either through outpatient department or through home care. And we admit patients till they achieve satisfactory symptom control, and this usually varies from 1 week to 3 weeks, but there are some patients who might require longer stay. And you can see here this patient with his facial expression, we can understand that he is in severe physical pain, and you can see after giving injection morphine titration, he is smiling at us. So this is the type of change that we can make to each and every patient. And in addition, you can see we need to provide psychosocial and spiritual support. And you can see a patient's wife who, after knowing that her husband has a very advanced disease, she's actually given support by the doctors and nurses. It may be just presence, sitting with her for some time and talking to her. It is not always talking, even our presence itself is a type of support that we are giving. And you can see on the right side, a gentleman with an elderly woman, and you may think that he is the son of the patient, that elder woman, but he is one of our volunteers. So that is the type of psychological support, or that is the type of bonding that we want to make with the patient, so that they will be able to express their feelings and their psychological problems to us, and we will be doing something to relieve that psychological distress. And we do end of life care for patients, and we all know that each of us want to die in peace, and we want to have a dignified death. So respect patient wishes Some of them want to die at home, some of them want to die at hospitals. And sometimes when patients die, probably the family members will not be allowed with the patient, or only 1 or 2 members can stay with the patient. But we want the loved ones with the patient. And we should also give control of symptoms. We know that if the patient dies in severe pain, and we all fear that, isn't it? If we die in breathlessness, what would be the feeling of the family member when they look back after the death of the patient? Then they will surely they will have distress in their mind. My loved one died in distress. So we would like to take that distress. We would like to take care of that distress. You can see here a patient. So this is a patient with carcinoma of the hypopharynx. You can see he is with a tracheostomy, and there is an ulcer, and he was in severe distress. You can see how he is sitting. He is always in this position because of severe pain and the fibrosis in his neck. But the family members, all of the family members in very distress. They were unable to see the scene that their father is suffering. And actually, you can see on the right side, now he is peacefully sleeping. So, if he dies in this severe pain, what would be the family members feeling? So, it is very important to provide end of life care properly, so that the family members will remember us. But if you manage end of life not well, then they will never forget you. So it is our duty to manage end of life care well, like we cure the disease. And this is a pediatric patient, 1-year-old baby who is diagnosed with the Meningitis disease. And you can see he is in the intensive care unit, where the mother actually was finding it very distressing, not only for the patient but also for the family. And after discussion with the family, we brought this patient to Palliative India, and you can see she is sitting with her child and her husband, and you can see how this patient is given, this patient and family is given the psychological support. And you can think of the mother who is the mother of a 1-year-old baby who is suffering from an incurable disease. And what would we have psychological problems? There would be relationship problem within the family. And she told us there is nobody to hear her distress. And so it is important to provide psychological and social support as well as symptom control for the baby. And this was during the Christmas days, the baby was admitted, and we actually involved the baby as well as his mother in the celebrations. And you can see our nurses is how they are taking care of the baby. And we have outpatient units in Medical College at Trivandrum, and the Department of Pediatrics at SIT Hospital Trivandrum, and we also work with other government hospitals. And in addition, we work in the community in many places in different parts of Trivandrum. And in pediatric palliative care OPD, we actually work along with the Department of Pediatrics and Pediatric Neurology at Government Medical College. In addition to this pediatric palliative care OPD, we also conduct an OPD at Trivandrum Institute of Palliative Sciences on every Saturday in the morning hours, so that the children, they can come along with their parents, because it is a holiday on Saturday. You can see these are some photos from the Pediatric Palliative Care OPD, and we also celebrate Pediatric Palliative Care Day. We will take them out to some of the places, and you can see this is an aeroplane, and how the children are enjoying getting in the aeroplane. So I would like to show you a video here. Rajlakshmi, is this video visible?
Video is visible, sir. Can you play?
Uh,
But we are unable to hear the voice.
yeah, it's okay, but you can listen.
Yes, sir.
Is it only me seeing it vertically rather than horizontally?
No, sir. Like that. I'm unable to. Okay. Rajlakshmi, is this visible?
Yes, sir. It is visible.
So you can see this young boy who was actually describing about his pain, and he was also crying in pain, and he had an acute demyelinating disease, uh, and he was describing the pain all over the head and the neck region, and he was tried on many medications, but his pain was relieved with small doses of morphine, and you can see the difference, how he smiles after the pain is relieved. So that's the type of difference that all you can make for this uh, uh, pediatric patients. So it's our duty also to make them comfortable. Okay. So we also conduct an OPD at Medical College Hospital in Trivandrum every day from 1 to 4 p.m. And I just want you to show transformation of a patient in the MCH OPD who came with severe pain. You can see the patient who is sitting down with his head down. See this. And after giving IV morphine titration, you can see the patient's transformation. And so all these patients give us enough strength to go forward. It is not only about death and dying, but we can improve the quality of life. We can make a lot of changes in the life of many patients, not only patients, but also their families and a lot of friends. So it's very important for us to work in this field. And we do home care in the district of Trivandrum with the help of community volunteers. You can see there is a team consisting of a doctor, nurse, and volunteer. And in various parts of Trivandrum, we do home care, and we do it with an interdisciplinary team, which consists of doctors, nurses, physiotherapists, medical social workers, then various other support workers and we provide all the type of supports like physical, psychological, social, financial, and spiritual support. And we actually want the patient to get empowered in the care of the patient. And you can see this patient has a pressure sore, And once we go there and give care to the patient, then the patients should not wait for us till the next 2 weeks. We should actually teach the caregiver how to take care of the patient. So that's the most important aim of home care. And you can see there are all the types of patients for whom we provide palliative care, and we provide rehabilitation and in the community itself, and we have physiotherapists working in the community to provide rehabilitation support to the patient. And we provide monthly food kits to those families who are unable to find out their livelihood. And you can see the volunteers carrying the monthly ration for the patients. And we also provide educational support for the children of these patients who are actually unable to go to school because all the money would be diverted for caring the patients. So it is very important for us to take care of these children. And we have a halfway home where we actually rehabilitate the patients with neurological problems. You can see one of the paraplegic, he is making some art forms, and so we provide both physical and vocational rehabilitation to make them live independently as much as possible with the help of our interdisciplinary team. And we also provide telehealth care, which actually started during COVID-19 pandemic, but now we are providing it from Monday to Saturday from 9 to 4:30 p.m. A doctor, a nurse, and a social officer would be there, and we provide support in Malayalam, English, Hindi, and Tamil. And these are the two numbers from which the patients can reach to us, or even professionals can reach to us through this number if they want any help in palliative care. And I told you we work in a model of demonstration, education, and facilitation. So we have a lot of training courses for doctors, nurses, and volunteers. So we provide both on-site and online courses. So there is a 6 weeks certificate course for doctors and nurses, and an online course, which is an integrated course in palliative medicine, which is a self-directed online course with a few live sessions. Then another 1-year program in palliative medicine is the Global Fellowship in Palliative Medicine for doctors, and this is the time where we have called in applications. And if any of you are interested, you can visit our website for more information. And we also do faculty development program for faculties in the medical colleges for integrating palliative care into the undergraduate curriculum. And this is our team. Thank you for hearing. And if you need any support in palliative care, please let us know. Thank you.
Thank you, sir, for taking us through the whole of tips and saying regarding the activities of Pallium India. Definitely, this brings to the end of the session. And before we take up the questions, I think the session was really helpful for many of you. The topic pediatric palliative care is very relevant. And as I said, in Rajagopal sir's book, The Walk with the Weary, we have a lot of stories of patients, especially pediatric patients. Feel free to buy the book and read about his experiences in taking care of children as well. So we had some questions in the chat box. We'll go through few. Sharat Kumar has asked regarding the acceptance of death. Will it have any legal problems when we go ahead with acceptance of death?
Sangeeta, before going to that, I would like to acknowledge that the pediatric pain video is from one of our friends, Dr. Punitavati from Coimbatore. Yes, Vinita, please. Sorry, Sangeeta, please.
Sorry, Sunil, what did you say? What was it about Punita? I did not understand.
No, the pediatric pain video which I showed was from Dr. Punita.
I think she's there in the group. Maybe, ma'am, you can unmute and speak. If you can please share the experience.
Dr. Punita, are you there? You can unmute now and speak.
Okay, maybe we should go ahead. Maybe when she joins back, we can try once again. So can we take questions now?
Yeah. I think
Yeah, so
there
the
are some questions in the chat.
Yeah, one
I
question
think
was
many,
regarding.
Sangeeta,
Yes,
some
sir.
of the questions need elaborate answers, which we cannot do now. Like, how do you overcome resistance to the starting of palliative care from the team? Like, how do you provide psychosocial support? These are questions that need elaborate answers. And maybe you need to follow up with specific topics in pediatric palliative care so that they can have the answers to those questions. I cannot see in 2 minutes Sunil or anybody answering those questions. Many of them,
Yes,
some of them can be answered.
Yeah, some of the questions are related to the spiritual support that you give to a child. And how do we deal with end of life situation in children? How do we counsel them? These are some of the questions that has come up in the chat.
Sangeeta, would that be covered by John Marston in the next session? John, would you?
Sir, I think Joan Master is not there in this session. I think she has a connectivity issue.
She has a problem that South Africa has power shutdowns through much of the day. You will have to think about it about her session also to get a previous recording, because the power outage will keep coming there for many hours a day. So let me try to attempt that answer. I'm sorry, you cannot really condense it to a few, but I'm sure John Marston will cover it hopefully. But to give you 2 points. One, to make them feel connected and loved. We already talked about parental separation. The feeling that they are loved, the feeling, and also ensuring that they are where they want to be, like the home or a particular place. They may want to go back to the school for a visit. They may want to get together with friends. And these are very important things to ensure. Answering about spiritual, I'm not going straight to God and other things, but keeping them connected and making them loved is the most important thing in spiritual support. And as far as the faith is concerned, I remember a child asking me, will God not punish me when I die? If they trust you, they will ask the questions deep inside. And when the child asked, will God punish you? I asked the child, hey, the child was about 9 or 10. I asked the child, hey, do you think God is a good person or a bad person? He said, God is good. Then do you think he'll be so cruel as to punish small children for small mistakes that they do? And the boy said, no. And that was it, finished. It may not always be like that, but very often it is immediate solutions. They also have fears about death. Will I suffocate when they bury me? And again, an honest statement, no, When you die, you don't feel anymore. You will only have peace. And unlike adults, children accept these answers if they trust you.
Sangeeta, I can see Dr. Punita has joined.
Yes,
Sunita?
sir. I have called her. Yes.
Yeah, I have just shown the video for the young patient who had acute demyelinating disease for whom you started on morphine, and after starting morphine, what a big difference that was made. So just give 2 minutes on what has happened.
Yes, sir. I can share my experience about giving oral morphine for this child. Basically, I was apprehensive to give morphine for this because in pediatric population, I have never used morphine or before. But now, after coming to Pallium, I could get in touch with Dr. Sangeeta to guide me how to start using morphine. This was acute demyelinating encephalomyelitis for a patient who had some viral fever, and after that he was having severe headache. And he used to bang the side railings of his cot to manage his pain in the night and all. So for 3-4 days they were managing with ibuprofen and paracetamol, but they have crossed the upper limit of the dose already. So what happened was the pediatricians reached out to me, knowing that I'm doing adult palliative care in my hospital. They asked, could you help us, because we have reached the upper dose of analgesics. We don't know how to help now. Can you do anything? Then I spoke to Dr. Sangeeta, and then I started on oral morphine. Initially, I gave him, I was so scared, so I gave him 1.5 mg BD. My pharmacy is very good. Whatever concentration I ask, they make syrup accordingly. So I asked them to make 1 mg per ml of morphine oral syrup. They made it. So I gave 1.5 mg in the morning and 1.5 mg in the night. For the first day, the parent could tell me, even the patient himself could tell me that after this medicine, he is good for 4 hours. So then I increased the dose to 2 mg. With 2 to 2.5 mg in the morning and night, patient could have good relief, and I increased the dose frequency of the dose also as TID. Then in 7 days, the patient had good symptom relief. He was sleeping, he was playful again. His oral intake increased, and I think you all saw the video also. After 7 days, I reduced the dose to BD and then OD and SOS and stopped. So this was a very short usage, sir. I used this only for 10 days or so. Weaned off. After 2 weeks, the patient was out of morphine, and his other curative therapy was going on. He did well. Now he is discharged. He is doing well. Thank you for letting me share this this experience of mine.
Thank you, Punita.
Thank you, ma'am, for sharing that. And thank you, everyone, for taking part in the session. I think we are 2 minutes past our time. There are a lot of questions which are more complex and needs detailed discussion. And I don't think we can take it up now. So can we wind up the session, sir?
I think if Sir want to tell us anything more regarding the questions that has been in the chat. Prasad sir, would you like to answer any of these questions? And after that, we can wind up.
I think all this questions, as Rajagopal sir said, all these are questions which need elaboration, like how to deal with preventing suicide at thoughts and parents and your child, etc. So I think we'll have a final word from sir, and we'll wind up.
No, but thank you. I only apologize to everyone because this is only an introductory session. Many of the questions that you have put upon the chat box are need elaborate answers. And Rajalakshmi, I hope you have copied all the questions. And between the team, it will be good to create whatever at least references you can have for these things and these questions, and to give some answers. I'm not sure that many of the questions can be answered easily. To the person who asked the question about the Kubler-Ross book, it is not specific to children. To the best of my knowledge, none of the books written by Kubler-Ross, I have given a link here. There are so many books. None of them deals only with children, but almost every book has significant sections on children because she did not run away from meeting children where they are. And there will be very educative stories there. So please understand that this is only an introduction to the whole thing, and detailed answers could not be given. Apologies for that. Back to you, Sunil.
Sangeeta, I saw that there are a few questions from Global Fellowship in Palliative Medicine, and I think if you can go to Pallium India website and go to the training session, you will get all the answers that you want. And if you need to contact us, please contact us in the email ID given in that website. And Sangeeta, shall we wind up then?
Yes, definitely.
Sangeeta, so sir and Sunil, so please quick answer. There is a question: to what extent are children allowed to be part of the decision-making process? It is true that legally, till the age of 18 in most countries, it will be the parents who have the legal authority to take decision. But that does not mean that we should not involve the children. Involve the children fully. And when there are conflicts between the child's wishes and the family's wishes, encourage open discussions. And this is the only way of handling it. Okay, that was one quick answer to that particular legal question. And there was another question about legal aspects, which was not very clear to me. So if you have copied the questions, we may try to find answers for all of them. Thank you very much.
Thank you, sir. Thank you, Hariprasad, sir. Thank you, Sunil, sir. And thank you for every participant who have joined us today to make this session a wonderful one. And thank you for your active participation also. So with this, we wind up today's